ICS members, guests, and moderators, thank you for this opportunity to present our work. I'm Amy Dauberful, a urologist from the United States. So here are our affiliations. We have no conflicts in relation to this presentation. So some acknowledgments. This was approved by an IRB at Stanford University and supported with a KL2 Career Development Award. So some background, anti-incontinence, typically sling surgery. It's been the subject of many large clinical trials. Primary outcomes are focused on subjective and objective measures of stress and urgency in incontinence. The impact of sling procedure on changes in post-void residual over time has not been fully reported in the literature. Our aim was to improve patient counseling on expected PVR changes in women considering a sling procedure at time of prolapse repair. So we sought to create a cumulative incidence model of this. So our population, we identified sequential records over a 6-year period which contained preoperative urodynamics, followed by anterior and or apical prolapse repair. Our inclusion was at least stage 2 plus cystocele, at least 7 days of follow-up afterwards, and we excluded patients who had sling removal. A 2-reviewer chart review was conducted of all urodynamic tracings and surgical characteristics and follow-up residuals after surgery. This identified 143 women with chart-reviewed verified preoperative urodynamics followed by post-void residuals. So our primary outcome was time to first instance of PVR greater than the preoperative PVR prior to surgery. Our secondary outcome was longest follow-up post-void residual greater than preoperative PVR. Data were analyzed in SAS, and we used Kaplan Meier cumulative incidence methods to do such. So this resulted our population had a mean age of 62 years. Most had stage 2 or stage 3 prolapse. Preoperative urodynamics demonstrated a detrusor pressure of 20, Qmax of 17, and residual 115. Our interventions included anterior only in 66, apical only in 21, and combined anterior apical prolapse repair. 83 patients had sling placement, and 60 had no sling placement. Most of these were TVT versus retropubic. Sling placement was performed in 83 women. No sling placement was in 60. Our only significant difference between these two groups are in our no sling group, they had a higher preoperative PDAT at Qmax and PVR in the no sling group. And these were, TOT and also TVT slings. So in follow-up, women were followed with a PVR for a mean of 587 days. At least one PVR was recorded in all women. Sling placement, these patients had at least a mean of 3 PVRs, and no sling, a mean of 2.3 PVRs. To look at the transient effect of the sling, first instance of follow-up PVR more than preoperative was assessed. So that figure is shown here for 30, 60, and 90 days after surgery. What we found is the sling was associated with a greater proportion of women with a first instance of follow-up PVR worse than their preoperative PVR, with a significant hazard ratio. When we followed this out to 2,000 days, we did find that fewer patients were at risk at 500 plus days after surgery, and there was a similar proportion of women with first instance of PVR worse than their preoperative PVR. But here you can see separation of the incidence lines at all points after surgery. Now when we assessed looking at the longest follow-up, so the last PVR on record for each patient, we see a similar proportion of women with longest follow-up PVR worse than their preoperative PVR for the first 30 to 90 days after surgery. And here you can see the lines completely overlap, so there was no difference between sling versus no sling. So our limitations, this is retrospective. Selection bias is certainly consideration who was offered sling. Sling removal patients were excluded. There's obviously natural variability in the PVR measurement, straight cath versus bladder scanner. And we didn't report subjective outcomes, urgency and stress incontinence in our model. Our strengths, though, are the large number of patients for this type of study and repeated measures of PVR in many women. So our interpretation, sling placement is associated with a transient worse PVR after surgery, and there's no significant difference in the proportion of women with versus without sling who had long-term follow-up PVR worse than their preoperative PVR. So our concluding message is that women considering a sling at time of their anterior or apical prolapse repair, transient elevations in PVR should be expected as part of the natural history, but there was no long-term significant difference in hazard in the group that we present. So any questions, if we're not able, you can email me. Here's also my Twitter. So.
Any question?
Pando from Spain. I think we are not able to conclude the second conclusion if we exclude as the sling removal.
Yeah.
Because it's important. Because this, how do you know how many patients do you exclude?
I don't have that number off the top. In a larger group of around 220 patients, in another paper is around maybe 12 who had sling removal.
But this is very important because the conclusion is if we decide to perform the surgery at the same time or not. If we read this paper, we can decide, okay, we decide to do the surgery at the same time, but that's not the real results. So we have to decide to put all the patients, and we need more studies to decide if we have to decide to do this at the same time. We don't do at the same time, and we reduce our slings at more than 50% less. So I think we need more studies.
Yeah, that's definitely a good point. This population that I'm presenting here are only patients who chose to not have their sling excised or removed or incised after surgery.
Yeah, it's just not clear in the methods or your results at all how situation. I think, you know, for publication of this study, we need a lot more information about patients who chose not to have their sling removed. What does that exactly mean? Mm-hmm. And, you know, how many were there? And some people choose to have their sling removed because of pain or extrusion. Other people have their sling removed because it's obstructed, which is directly relevant to your hypothesis. Mm-hmm. So if you don't provide that information, the reader can't make any conclusions from the study.
That's excellent feedback. Thank you.
Did you evaluate the irritative symptoms or the incidence of de novo UTI in such group of patients with sling?
Not in this particular study.
Oh, because that would be clinical relevant. That means just to reinforce your conclusion of the message. It would be important.
Thank you.
Thank you. Thank you.
Thank you.